Hello. This is the Comparative Ocular Pathology Rounds with Coplow. My name is Megan Klimans, and we'll get started. All right. There we go. So this is a 6-year-old spayed female Great Dane. They describe a retinal detachment in the left eye. There is a diagnosis that I will withhold in both eyes. And they describe ongoing uveitis in the left eye with no light perception. So they enucleated the left eye, and we'll take a look at the gross first. See if I can make that go away. I think probably the people at home can't see the thing on top anyway. So we have an eye. We'll start from the front and go back. We have the iris up here, and it often looks to me like it's kind of got vanilla frosting on it, these irises. And that is a blue iris. So the blue color of blue eyes is more of like a structural phenomenon than a pigment. So a sectioned eye and a formalin fixed eye will tend to have like sort of this grayish look on the surface. So this is a blue eye. We can also see that one side of the iris, this iris leaflet, is much shorter and stubbier than this side. And indeed, the gross examiner in this case described a choractopia, which is basically a displacement of the pupil, in this case, displaced ventrally. This is roughly the site where the optic nerve head would be. You can see that this half is the shorter half or the ventral half. So a stubbier ventral iris leaflet and a pupil that's been shifted kind of ventrally. It's difficult to tell which side is ventral or dorsal otherwise because the tapetum in this case is generally hypopigmented, which is part of having a blue eye. We've got this hypopigmented fundus, which is hard to tell which side would be tapetal and which side non-tapetal, except for this area here, where we have this sort of patch that is pigmented, and we can make out ciliary body plicae at this level. So see these lovely folds that look like mushroom gills. Those are lovely ciliary body plicae. And then there's another thing that we can see on the gross exam that's interesting, and I'll kind of outline it here. The ciliary body is kind of like abnormal in this site, or particularly abnormal. There's this weird area where there's sort of less tissue there, maybe a slight like absence. And we'll take a look at that later. The retina here is detached. We can see it's sort of folded on itself, this sort of thin tissue paper-like tissue. All right, that's the gross exam. Let's take a look at histology.
Was the optic nerve in that, Megan?
I am not sure. It may be an other half photo.
Okay. I was just
that was like the level where the optic nerve kind of would be roughly.
That's fine.
Yes.
It is the other half.
It is the other half. Okay, confirmed. It was the other half. I thought it might be, but I wasn't sure. Okay.
By the other half, we mean that when we cut the eye in half, we send the half with the optic nerve for histology. Sometimes when we want to take a picture of something that we were like, oh, looking cool to take a picture, we take a picture of the other calotte or the other half of the eye without the optic nerve.
Indeed. The half with the optic nerve was already submitted. And we have it here. So we have a couple of levels, and I'm going to show you my favorite level. Let's see. So we have the cornea to our right, just to orient you. And actually, we're going to start at this level here. So this level is very interesting. We have ciliary body plicae here. So this is what normal ciliary body plicae look like. We do have a pigmented and a non-pigmented ciliary body epithelium, which is what you expect in most eyes. The not pigmented is sort of deep to the non-pigmented, and all looks kind of well here. Up here, though, there's an unusually thick sort of iris-like tissue crossing the reticorneal angle and directly contacting the terminus of Descemet's. There's a bit of a ciliary cleft here, maybe, but it's kind of not well formed. There aren't really distinct pectinate ligaments necessarily, maybe like a somewhat narrow trabecular meshwork, and we can still see the vessels of angular aqueous plexus. So something's up, but it's not like as obvious. But if we go over to other areas or other quadrants of the globe, it's much more obviously abnormal. So on this side, there's this thick sheet of iris-like tissue that's crossing the angle. There's no evidence of a ciliary cleft or trabecular meshwork at all. There are still vessels of angular aqueous plexus, which is kind of neat. But otherwise, the aqueous outflow pathways are pretty malformed and closed up. We do have some other abnormalities. So we saw sort of what more normal ciliary body plicae look like. In this area, things are kind of jumbled. So the base of the iris sort of directly blends into this area that kind of looks like it's trying to be ciliary body, but there aren't really like well-formed plicae. It's mostly just this sort of jumbled neuroectoderm and sort of neuroglial or retinal-like tissue, all sort of mashed in together. We don't really have a distinct pars plicatum ciliary body or pars plana, and we don't really have like a distinct ora serrata at this level. So there's a little bit of malformation. We'll come back to that site later on higher magnification, but first on low magnification, I want to show you our additional radial section. Again, similar findings in terms of distortion of the ciliary cleft and trabecular meshwork and the iris-like tissue crossing the angle, and basically even less of an obvious ciliary body here. The iris just sort of blends immediately into this sort of flattened tissue here, with no ciliary body plicae really present at all. So basically on our gross view, that pigmented area of the ciliary body where you could make out the plicae grossly was actually sort of the somewhat better formed area, and then the non-pigmented areas were pretty showing some pretty significant malformation. If we continue to go back on this radial slice, we see some additional interesting findings. So we do have some stroma of the ciliary body here and kind of an ora serrata. And then here in the choroid, suddenly that uveal tissue is just gone. And we just pretty much have sclera. And then it picks up again really suddenly over here on the other end. So that's interesting too. And we'll take a look at that closer. Start by coming back up into this area. I mean, the cornea is okay. So if we look into this sort of area here, we had all this tissue sort of blending together. We do kind of have a first plica of the ciliary body. So again, we have the pigmented and non-pigmented epithelium. We kind of have a stroma here. So there's some degree of plica formation, but like the neuroectoderm is sort of blending into this disorganized kind of primitive looking neuroglial tissue. And then we also immediately adjacent to that have these cute little vessels. They're really well formed, sort of small diameter vessels right next to the ciliary body, kind of in the posterior chamber or anterior vitreous. Hard to tell exactly where. And there's not much stroma associated with these. They're just sort of well-formed naked vessels. In a lot of cases where things may have been going on for some time, it's very difficult to tell apart sort of a congenital anomaly in terms of persistent fetal vasculature. So basically when you're a fetus and your eye is developing, there's vessels all throughout the eye feeding the developing structures. So there's vessels in the vitreous space. There's a big hyaloid artery that runs from the optic nerve head to the back of the lens. There's a really adorable like thin coat of vessels all around the lens called the tunica vasculosa lentis. But all of those vessels contain blood, and blood is opaque. And they are lovely, thank you. I agree. Oh, they okay?
Yeah.
Okay. Oh, all right. Okay. That thing at the top finally went away too, which is nice. So those vessels are opaque, and opaque things block light. So ultimately, under normal circumstances, those vessels are all supposed to regress as the eye develops and as the animal becomes, or as the mammal becomes an adult. So if they stick around, it's called persistent fetal vasculature. Oftentimes, persistent fetal vasculature is a clinically incidental finding, unless it creates significant opacities in the visual field, or sometimes cases will present with kind of chronic intermittent hemorrhages inside the eye, which can cause trouble. And there is a little bit of hemorrhage in this eye, which is interesting. But it is often very difficult in cases that have kind of gone out a little ways to distinguish between an acquired fibrovascular membrane, like sort of neovascularization, versus sort of pre-existing fetal vessels that failed to regress. That said, in this case, I strongly suspect that these vessels are persistent fetal vasculature. There's not much of a stroma supporting them. They're just sort of floating out in the vitreous. Plus, there are other congenital anomalies in this globe. So it is a reasonable explanation that these vessels are here because they failed to regress. Anyway, that was a long amount of discussion for that. We can kind of come back here and see this sort of primitive neuroglial tissue blending into retina without like an obvious ora serrata. There is a bit of cataract. It's worth pointing out that maybe some of the cataract is changed is a little bit like a deeper, sort of deep cortex. So it could be a congenital cataract in this case. It's not really classic for a congenital cataract. I'm not going to spend too much time on this. We're gonna go over here and look at this area. All right. So we have this area where we still have uveal stroma, and then suddenly that uveal stroma is gone. And instead of uveal stroma, what we have here bridging the gap is again kind of primitive neuroglial, neuroectodermal type tissue. That's an artifactual gap there. But here we have it picked up again, just very thin layer of sort of primitive, sort of disorganized tissue. And then suddenly the uvea is back. So this is an area of absence of tissue, congenital, and so we call that a coloboma. Coloboma is sort of an area of absence congenitally in tissue. So choroidal coloboma, kind of roughly at the equator of the globe. Some may refer to this as a quote unquote atypical coloboma. The more, I guess, common or typical colobomas happen right next to the optic nerve. There is sort of a fissure there during embryologic development that is supposed to close as things develop. And it's kind of one of the more common spaces for things not to fully close up and for you to develop a coloboma. This is sort of a less common area of coloboma, but we still see colobomas in these areas.
Do we know if this is dorso or ventral?
We don't really histologically. Grossly, we described a ventrolateral absence of the ciliary body, so it's probably ventrolateral.
Yeah, that makes sense because the optic cup closes ventrally, embryologically. So when that doesn't happen, creates these colobomatous lesions, and it's usually ventral. Some people will call dorsal colobomas atypical colobomas.
Okay, so maybe this is
Ventral
still
one's more
kind of
typical.
technically atypical. Okay,
Yeah,
all right.
but again, it doesn't really
Either way.
kill poison. So nice section to the optic nerve. Look at it.
Yeah, it's kind of cute. You can see the meniscus really nicely. Adorable. So the retina is detached. We can see the hypertrophy of the ciliary body epithelium. In some of these cases with congenital anomaly and sort of long-standing retinal detachment, you can wonder if it was a congenital non-attachment versus sort of a detachment acquired later in life. Another thing about embryology of the eye, the neurosensory retina and the RPE are sort of not directly opposed during development, and they kind of come into contact as development progresses. In some cases, they never oppose, and then you can call that a congenital non-attachment. And in other cases, it may have opposed at some point in the patient's life and then detached later. It's extremely difficult to tell histologically between these things. You can have basically no retinal dysplasia to like really severe retinal dysplasia in either case, sort of an early life detachment or a non-attachment. So you can always sort of DDX them if there's other congenital anomalies in the eye, maybe, but it's very difficult to tell them apart histologically, and also not really, there's not much point to the patient in telling them apart. It's an academic distinction. But this retina doesn't have a dysplasia. It's just detached and is showing some outer atrophy. We still have a nerve fiber layer and maybe sort of an inner nuclear layer through here, but not much photoreceptor segments or nuclei. Maybe up to a full thickness atrophy in some areas. But basically just a retinal detachment, maybe congenital non-attachment, which they also described.
Can you remind us of the signalment again?
Oh, this is a 6-year-old Great Dane, which is interesting because the patient is fairly, adult at this stage. Spayed female. They do note that the Great Dane's hair coat is white. So yes, I withheld many pieces of information so that you guys could kind of follow along and make some thoughts as well. We have multiple congenital anomalies in this blue-eyed, white-coated animal, and this is consistent with Merle ocular dysgenesis, sort of first and foremost, and that's the diagnosis that they had in both eyes that I withheld primarily. Merle ocular dysgenesis can present with a variety of different congenital anomalies. They can be like one to many, and like different types of congenital anomalies. There are some that may be more typical than others, but basically just congenital ocular anomalies.
Did you thought the retina was dysplastic, Megan?
I didn't in this case,
Yeah,
no.
me neither.
Yeah. So yeah, there are some diagnoses there, a lot of sort of differentials, because I think some of these cases, it's difficult to tell between congenital versus sort of acquired later in life things. But yeah, that's this case. If there aren't any other questions or comments, I'll move on. I feel like I already took forever to talk about fetal vasculature. Okay. This next case is a 9-year-old and neutered male Boykin Spaniel. They describe an optic neuritis, episclerokeratitis, anterior uveitis, and retinal detachment reattached. And it's not entirely clear whether they mean that the retina detached and then sort of reattached on its own, which is something that can happen, sort of if there's like a serous retinal detachment, the fluid beneath the retina can kind of resorb and it can sort of reoppose on its own. Or if they mean like the surgical reattachment. So silicone oil endotamponade usually is how they reattach a retina in a dog. I won't go into detail on that surgical procedure. You can do that in your own time because I'll take up too much time. But so there's a possible surgical reattachment versus reattached on its own. And indeed, the gross examiner thought that the contents of the eye were maybe a little unusually viscous and thick, consistent with silicone oil, but kind of like, not entirely sure. So we're still kind of like sort of DDXing between like, was this eye sort of surgerized at some point or not? We do see in this gross view that the sclera is pretty remarkably thickened, particularly on this side of the section. And we do have all of these lovely dit dots in the vitreous. They're lovely for a pathologist, probably not for the patient. These are what would probably be referred to as floaters if you had those in your eye, for example, and they probably would be quite annoying, particularly in these numbers. But they're very pretty at gross exam. These guys are asteroid bodies, so this is an asteroid hyalosis, a pretty severe case, actually. They kind of look like the Milky Way, very cosmic, kind of pretty on gross exam.
How common would it be to see asteroid halosis with silicone oil vitreous injection?
Yeah. Yeah. Oh, so probably not. Actually, that is one of the things that suggested that it was this eye probably wasn't surgerized. The part of the procedure for silicone oil endotamponade is a pars plana vitrectomy. So usually they go in and they remove the vitreous and then replace it with silicone oil. So that we have this, the fact that we have this many asteroid bodies in this eye was one of the things that suggested it wasn't surgerized. Good point. Yeah. Also, I mean, also a lot of the cases of silicone oil endotamponade undergo phacoemulsification with an IOL implant, which is another feature that kind of suggests maybe this eye wasn't surgerized, but not all. Basically, the silicone oil actually is kind of toxic to the lens, and you can get cataracts down the line if you leave the lens intact, which is why a lot of those cases get phacoemulsification with IOL. So also another point towards sort of not being surgerized. Okay, I think that's all I have to say about the gross. There. Let's see, we can do a little bit of, wait, yes. All right. So trying to get kind of a subgross in, you can see that the sclera is indeed quite thickened, and the staining characteristics of it are a little abnormal, kind of a heterogeneous staining with sort of paler looking patches. There's also a good amount of basophilia in there, but it's actually not particularly hot. Even the sclera on the other side that's not as overtly thickened is looking a little bit abnormal in terms of its staining characteristics from low magnification. Let's take a closer look. So here we are on this side of the abnormal sclera. Our cornea is to our right again. But we'll start with the cornea. I'm just going to go front to back. I swear I'm not trying to ignore the elephant in the room. There's just too much interesting things to look at in the side. So in the cornea up here, sort of paraxially, we have quite a bit of chaos. We have some neutrophils, and then in between the neutrophils, you can actually see this deeply basophilic material. Oftentimes it kind of looks paler staining in the middle, kind of this granular nature to it, which is interesting. But ultimately all of this stuff, including the kind of weird bubbly looking stuff, is mineral. You can also see this mineralization sort of up immediately under the corneal epithelium. Possibly mineralization of Bowman's layer is what we're seeing here. And this sort of layer of mineralization we would typically call band keratopathy, but because there's just so much mineral in the corneal stroma in general, I usually refer to cases like this as calcific keratopathy. Clinically, some people may refer to this as calcific corneal degeneration or mineral corneal degeneration. So there are some things there. But calcific keratopathy is how I would diagnose this, pretty significant one. And then another kind of neat feature in this cornea is if you walk over a little ways more peripheral, there's this kind of cute little deposit here with these clear acicular clefts. So acicular just means needle-like, and here they are. And then sort of associated with that, very small numbers of foamy macrophages. Foamy macrophage. So this is a really subtle lipid keratopathy. Both the lipid and mineral look kind of shiny and white opaque in a cornea clinically and grossly. And it can be difficult to tell them apart grossly and clinically. This case just happens to have both mineral and lipid in the cornea, so that's fun. There are some interesting broad breaks in peripheral Descemet's membrane. Kind of could be like a surgical incision, but again, we're kind of favoring not surgerized, which suggests that the breaks may have happened for some other reason. But here they are. So we have one end of Descemet's, we have corneal endothelium sliding across that gap, which is what it does when Descemet's breaks. Here's the other end of Descemet's. And this corneal endothelium, if you gave it enough time, would lay down a new layer of basement membrane in that gap. And then without further ado, let's look at the really cool thing, the giant thickened sclera over here. So if we look closer, most of this is just extra collagen. There's way too much collagen in the sclera, and that's why it's so thick. But a lot of the collagen is very abnormal. Usually normal sclera has this sort of regular intersecting stream sort of a look. It's very dense collagen, but it does have some degree of a pattern to it usually. This stuff is a little bit more disorganized. And then you have this alternation between sort of more like distinct fibers and then this weird kind of shmooey pale staining material, or sometimes kind of brightly eosinophilic staining. And then even collagen, which is sort of a low cellularity tissue normally, should have fibrocytes or maybe fibroblasts if it's being actively laid down. It should have some cellularity to it, basically. And a lot of these abnormally staining areas pretty much have no cells to them. So this is what we refer to as collagen devitalization. We say devitalization just to avoid using the word necrosis for a primarily collagenous structure, but some people might refer to this as necrosis of the sclera, essentially. But we prefer devitalization or maybe degeneration. Regardless, the cells are being lost and the collagen itself has this abnormal character. There's actually not much inflammation at this time, which is interesting because a lot of these cases have much hotter presentation with way more inflammation, but there are still a good number of inflammatory cells in some areas. And if we look at the types of inflammatory cells that we have, it's mostly macrophages, lymphocytes and plasma cells, and also some neutrophils and maybe some karyoretic debris here and there. So we have a pretty severe scleritis with devitalization of the collagen and this additional abnormal collagen laid down, and that this condition involves deposition of additional collagen that wasn't there before, is also kind of highlighted in some other areas. So this, you might think it could be just sort of some of this collagen bulging into the uvea, but there are also areas where there's sort of overt deposition of this abnormal collagen inside the eye. So here, right at ora serrata, we have this abnormal collagen and a little bit kind of in the choroid up underneath the RPE at variable sites, so sort of multifocally in this case. So that's kind of neat. If we walk over to the other side of the eye, we can see that even though it's less thickened, it still has similar abnormalities to the collagen. We can see briefly all of these beautiful asteroid bodies. They're very pretty. They're sort of this lovely lavender on histology. But we won't spend too much time on that. The retina does currently show signs of retinal detachment, but in cases of retinal detachment that reattached, whether surgically or non-surgically, it's difficult to tell whether these signs sort of happened while the retina was detached originally, or if it's currently detached or reattached or whatever else. So pretty much all we can do is describe what we see. There's a little bit of retinal atrophy. There's maybe a little bit of stuff beneath the retina. So there's some signs that it was detached at some point, at least. While we're back here, I don't have the condenser in while we're back here. Up here in the peripapillary tissue, some of these vessels, sort of these small arterioles and maybe the small caliber arteries are looking a little bit thick with corresponding narrowing of the lumen. It's kind of debatable. I think there's better ones over here. But basically, I think that some of these are a little bit thickened, maybe increased numbers of smooth muscle cells. So there's a suspicion of vasculopathy here. We often see hyperplasia of the walls or thickening of the walls with hypertension. So there's a suggestion that that might be going on. And there's also some vascular abnormalities in the central retina. And in particular, in these vessels, you can see that there's actually partial mineralization of vessel walls. So we have some mineralization in the vessels as well. And you can see maybe some mineralization also in the central choroidal vessels, some of these. So there's some weird mineral changes back here in the vessels, which were of note. So long story short, in this case, there are kind of a couple of interesting things going on. The main thing is this abnormal change in the sclera. And this is consistent with a condition referred to as granulomatous scleritis. You may also hear it called necrotizing scleritis. Again, we prefer granulomatous scleritis just because we don't like the term necrosis of sort of a primarily collagenous structure. But you will also hear it referred to as necrotizing scleritis. It is more typical cases or possibly more like recent onset cases maybe tend to be more inflamed with much more macrophages, especially, and then other inflammatory cells in them. But we do see cases like this. It's unclear what's going on. Maybe they had this patient on anti-inflammatories or something that was changing the inflammatory milieu here. Maybe it's sort of later in progression. But regardless, this abnormal change to the collagen and this additional collagen being laid down, so the sclera becomes quite thick. And then even though it's sort of milder and less broadly distributed, the inflammation character, the types of inflammatory cells that are there, consistent with the diagnosis of granulomatous scleritis. Granulomatous scleritis is a presumed autoimmune condition. It's kind of unclear what the antigenic stimulus is and why it happens, but it's suspected that it's some sort of autoimmune or immune dysregulation type condition. It's suspected that the target in these cases might actually be the collagen itself. In a lot of these cases, the inflammatory cells will kind of attack the collagen or appear to be attacking the collagen. But again, it's not really confirmed what the stimulus is. The cases in the literature that are reported are often reported as bilateral. That said, in Coplow, we have a good number of cases that are apparently unilateral. So for example, this patient, they described the other eye as normal. It is definitely possible that some of these cases that we think are unilateral may have become bilateral at a later stage, and we just don't have the complete follow-up to determine that. So basically what we tend to say in our comment is it's not clear if it is as always bilateral as it is reported in the literature. Some cases could potentially be unilateral, but generally this diagnosis is one where you would want to watch the other eye really close and make sure it's not going to develop similar lesions. So that's sort of the main diagnosis in this case, the granulomatous scleritis. And then the mineral changes are interesting in both cornea and the vessels in the back of the eye. Like most mineralization of tissues, you can broadly categorize it as either dystrophic, so related to tissue damage, or metastatic, so related to issues in calcium homeostasis in the body. And they didn't really report whether this patient has any issues with calcium homeostasis, but given that there's both vascular changes and corneal changes with mineralization, it's probably worth, checking an ionized calcium in this guy, or, calcium and phosphorus levels, things like that. But there's also significant inflammation and damage to both the cornea and, the vessels back there. So it could just be all dystrophic change. And then potentially a systemic hypertension, or maybe the vessels are just reacting because of the mineral or the inflammation or whatever else. But, also probably worth measuring or monitoring the patient's systemic blood pressure in a case like this. All right, I've talked too long already. That is all I have to say about this case.
I wanted to add one thing. It's really common for lipid keratopathy to develop when they have this necrotizing or granulomatous scleritis. So, like, for example, if they described lipid keratopathy in the other eye, even if they said it was relatively normal, I'd be a little bit cautious. Like, say, hey, there could be this inflammation occurring, even though it looks relatively normal.
Yeah, it's worth noting that lipid keratopathy is actually similar to calcific keratopathy in that it could indicate sort of systemic issues or local tissue damage. And a lot of cases are basically happening because of local tissue damage. So yeah, a good point.
So just a selfish request. I see that there's a bunch of pathologists online and some here. Just leave it on the comments what your preferred term for the collagen change we've seen here. Because you asked 10 pathologists, you got 11 different answers.
This is why I give both terms.
They're visiting from other places. What collagen degeneration, collagen change, which is my favorite one because it doesn't mean anything.
Also, this one is so unusual and because there's so little inflammation.
Yeah.
It's mostly fibrosis.
Yeah.
Right.
Which
That's
is
the thing.
actually probably a huge component of the disease in general, but
Right.
when there's a lot of inflammation, our minds are overwhelmed with the inflammation and not the collagen, the extra collagen that's
Yes.
added. This one is so like striking because we don't really have the inflammatory cells anymore or whatever.
They're kind of like change. It's a different reorganization of the extracellular matrix of the whole thing.
Yeah. And I think that, like I said before, the deposition of collagen in the uveal tract hyalinized collagen. That's good too. It's kind of like
Yeah.
glassy. Yeah. The deposition of collagen in the uveal tract, I think, also helps to highlight that it is sort of extra collagen. It's not just the inflammation that thickens the sclera in these cases. There's a thought that it might actually kind of be like a vicious cycle. Like you have inflammation, you have damage to that structure, you have activation of alternative pathways, like macrophages, like start to do their thing, and like you get some additional collagen like laid down, and then maybe that's still like antigenic, then you get more inflammation, and then like it sort of sets up this vicious cycle where there's like inflammation, additional collagen laid down. Then you get this like crazy thickening of the sclera in these cases. So yeah, really, really cool and really illustrative of that. There is extra collagen in these cases as well. That's part of it.
They're extra or different collagen, right?
Extra and different collagen.
Alternate splicing of the genes for collagen elaboration was being made, and you have extracellular enzymes produced by different cells to alter polymerization once it's formed. So you can have so many different
Ways
Factors.
to change collagen.
Yes.
I have always disagreed. Can you repeat what David is saying? Sorry, I'll see. Dr. Rick said one of the things that happens with collagen is that you can alter the way the collagen genes are expressed, and you can also, once the collagen is produced by the fibroblasts, you can change how it polymerizes just based on what enzymes are in the surrounding, milieu, and you can directly influence that by the number and type of inflammatory cells there. Like we've seen mast cell tumors with this really chunky hyalinized collagen. And that's not due to the mast cells, that's due to the mast cells talking to the eosinophils, and the eosinophils actually making the change. And so I don't agree with calling it necrosis, because I think it's a completely different process. If you want to call it necrosis, and you're talking about the cells that are making it, yeah, the cells are gone. There's
Yes.
necrosis of the fibroblasts.
Excellent. Okay.
That's my 2 cents.
I like it. I prefer not calling it necrosis either, so it works. Cool.
All right.
I will move because I've already taken up a lot of time.
How old did you say that dog was again?
That dog was 9.
What steps can be taken, like in the apparently normal eye at this point, if they were to start seeing some of this, like if a practitioner was starting to see some of this grossly, or is there anything that you would catch early?
This is a good question. So the question is, what steps can be taken to help the other eye, especially if it begins to develop signs? I'll definitely give you the caveat that I'm not like probably the best person to ask about treatment protocols. However, I believe what has been published is that you would try immunomodulatory therapy essentially, because it's thought of as an autoimmune condition. I don't know if we know whether like trying to do preventative therapy, steroids or immunotherapies is Allison Bentley, and she is the person to ask about treatment protocols. So take notes on that.
Asking before that,
Yeah.
if the dog was treated, if we know in the history if the dog was treated, because that could explain the lack of inflammation at this point.
Yes, and that is what I was wondering about, but we don't have any information on that in terms of what treatment protocols were already on board for this patient. And yeah, in terms of whether like preventative therapy might help the other eye or anything like that, I don't think that we know that yet. The jury is still kind of out on whether these cases are typically bilateral or not necessarily always bilateral and stuff like that too. So, but yeah, okay. Okay, I will shift.
You see a trichrome for that one?
Yes, the trichrome is abnormal, but that was going to be more discussion, so I cut it off there.
That's a good one. Okay. It used to be bilateral. I can't remember one that started unilateral and became bilateral. Interesting. All right. Hello.
My name is Kelsey Brown. I'm going to be taking us through the next two cases. I also did not pick particularly short cases, so I apologize to Dr. Shaw if she cannot get to both of hers. Okay, so I have two cats today. My first one is a globe from a 6-year-old male castrated domestic short hair cat. And the clinical history we received describes boophthalmos in this eye that was submitted, as well as severe corneal edema, corneal ulcer. And they performed an ultrasound on this eye and described thickening of the iris and ciliary body, cataract, lens luxation, and iris bombay. And they also checked yes for glaucoma, which would make sense looking at this eye. So this is the gross hemisection of this globe. Indeed, we do have pretty profound thickening of the iris and ciliary body. There's kind of this mottled tan and brown mass, and it is circumferential. It seems to be maybe not quite symmetric. So there's areas where there's a little bit more thickening of the uveal tract. On top of that, there is this kind of proteinaceous or gel-like material in the anterior chamber. The cataract, there are some kind of artifacts from how it sectioned the blade just kind of caught it funny, but it is cloudy. So yeah, the lens does have a cataract. And then posterior segment of the eye looks pretty unremarkable. We can kind of see the retina folded a little bit, but that's probably just an artifactual detachment, which we can see pretty commonly when we're hemisecting the globe. All right, we will move to the histology. Okay. Up here. Do my best to do a low power, but there we go. Rotate this. All right, so we have a rather large globe, which they did describe with thalamus. We did as well grossly. So the cornea is up top, holding as I focus here. And indeed, there is corneal edema, so quite a bit of pallor in the corneal stroma. I'll show that as we get a little bit closer. Moving back. There is definitely a mass effect in the iris and ciliary body, and it is circumferential, so both sides are affected. On this side here, there's quite a bit of necrosis of the iris as well. Focus better. You can ignore my dot, means something significant has happened though, probably. And then posterior segment looks pretty unremarkable. There's a little bit of atrophy of the optic nerve head, which supports the fact that there was glaucoma in this eye. All right. And rotate, hold up. Okay. And we'll focus. There we go. Okay. So we have our cornea on the left, and as we get more posterior, that will be all the structures to the right. So cornea, there is indeed an ulcer as clinically described. So here's our corneal epithelium, and then it tapers off and we have lost it. So there's a pretty significant ulcer taking up most of the axial to paraxial cornea. Stroma, as I mentioned, there's quite a bit of pallor. So maybe if we go more peripheral, there is vascularization as well. So looking past that, we kind of have more eosinophilic, kind of denser stroma. And as we move axial, there's a little bit more pallor, and all of those collagen bundles are separated out. So this is corneal edema, also as clinically described. And then, as I mentioned, yeah, pretty robust vascularization, which is a non-specific reaction. We see that whenever the cornea gets a little bit ticked off. And then we can also, if we look very closely, make out this dense eosinophilic basement membrane. This is Desmais membrane. And there are areas where you kind of start to see it get separated off of the stroma. There's kind of all of this necrotic debris that's dissecting between the stroma and Desmais. And then there's areas where I can go a little closer to show it, but it kind of just becomes more indistinct. So there's actually a pretty large discontinuity in Desmais membrane, which might explain the edema we're seeing here in the stroma. So there's no longer, corneal stroma no longer has the capacity to maintain its normal hydration. So we get this profound edema. So sometimes we'll call this corneal hydrops. All right, but not to ignore the elephant in the room. So there is a mass effect in the iris and ciliary body. This is a neoplasm, spoiler to everybody. Get a little bit closer. So starting in our iris. We can still make out some kind of resident pigmented cells here. So this is our pheomelanin, which we see in cats. It's pretty common to see in their iris stroma. So these are going to be normal non-neoplastic cells. As we move off into other areas, if I can get one closer. The stroma itself is much busier. So there is this spindle to kind of stellate cell population that's scattered throughout the stroma and infiltrating it. And a lot of these cells do have variable degrees of melanin pigment within their cytoplasm as well. And a lot of atypia too. So this guy has 3 nuclei. There's this really bizarre mitotic figure here. We can still see kind of a little sniff of melanin pigment within its cytoplasm. Here's another kind of big bizarre one. And as we move out, I probably shouldn't do in 40x. It'll take us forever to get there. There's a similar population of cells also within our ciliary body. So just variable degrees of melanin pigment. And as I've pointed out already, a few mitotic figures, we can appreciate how mitotically active this is. There are some areas where there's like 10 mitotic figures in a single field. So like here we have 1, 2, 3, 4, 5, 6, 7, maybe 8. So it's a pretty brisk mitotic rate. And there are some areas where that pigment becomes a little bit lesser. So areas over here where we have just more of these spindle cells without quite as much pigment. But so it's quite variable between fields. However, given the fact that we have these cells with melanin pigment within them, this is most consistent with a melanocytic tumor. And the fact that it's kind of confined to the uveal stroma, there's not really areas where it's extending past the uvea. We diagnose this as a feline diffuse iris melanoma. With these feline diffuse iris melanomas or FIDMs, there's kind of 3 varieties or flavors that we diagnose. The first being our early FIDM, which is where the cells are confined to the iris. The next one just being kind of your garden variety FIDM, which we just call FIDM without any modifier. And that's where it's going to be infiltrating the iris and ciliary body. And then anything past that is an extensive FIDM. So that's where we start to see scleral or choroidal infiltration. So in this case, we do have a little bit of choroidal infiltration and then kind of some areas where it is sneaking into the sclera as well. So this one would actually be an extensive FIDM. And there are some histologic criteria that have prognostic relevance. So one of them is being the mitotic rate. So mitoses over 7 per 10 high-powered fields. You're shaking your head? What's that?
There's more.
Okay, wow. What did I say?
No, I was.
Did I just say one?
Just saying, like, there's a couple more.
There's a couple more. Oh, that's fair. Like, oh no, am I misspeaking? Oh, thank you. So maybe more than a couple of prognostic criteria. That is true. There are many, many papers going over prognostic criteria for melanocytic tumors. For FIDM specifically, there are a few that we reliably look at histologically. So one being the mitotic rate, so for 7 mitoses per 10 high-powered fields, which this one had, I forget what my mitotic rate was, but it's well over 7. The next one being areas of necrosis, which I kind of skimmed over it, but definitely there's areas of pretty profound necrosis within this neoplasm. And the last one being a choroidal and or extrascleral infiltration, which in this case, we do have choroidal infiltration. So if we kind of check one or all of these boxes, then this neoplasm would be associated with a poorer prognosis, meaning it might metastasize more readily. If there were incomplete margins, then there might be a higher chance that it would recur. In this case, there are complete margins, but this is the type of tumor where staging probably would be of value. Okay, so we have that. If that's not enough, this lens also does have a pretty significant cataract, which is evidenced by all of these Morgagnian globules. We have areas where the lens epithelium is quite hyperplastic. We have posterior migration of that lens epithelium, which is another indicator of a cataract. And then on top of that, if we follow this, there's also a lens capsule rupture. Very cute. And everyone cheers, yay. And it's a pretty extensive rupture. If we follow it to wherever it picks up again, it is very cute. If we're not convinced that this is a ruptured lens capsule, which this one is particularly convincing, there is extralenticular migration of that lens epithelium, which we would not see with an intact lens capsule. And these are the cells, if we were to have a post-traumatic sarcoma, say, these are the ones that would transform and we would start to see pretty extensive infiltration, large mass effect in the eye. In this particular case, we don't have grounds to believe that this neoplasm is associated with this lens capsule rupture. It is possible that this neoplasm causes eye to be blind or poorly sighted, and we had blunt trauma and subsequent lens capsule rupture. So I guess we can make an argument that they are loosely related. But as far as we know, there is no post-traumatic FITM.
We've tried to diagnose it in the past.
Oh gosh. I want to open that can of worms.
Yeah.
And then lastly, this globe was diagnosed with glaucoma, which in cats, oftentimes we don't see profound retinal atrophy, but we'll see decreased numbers of ganglion cells. So there's one there as we kind of traverse the retina. Perhaps there are decreased numbers. It is somewhat subjective in this eye. But at the least we do have some atrophy of the optic nerve head. We have gliosis of the optic nerve. So we felt pretty comfortable calling glaucoma in this case. And we have very good reason for it with effacement of the drainage angle by this neoplasm. So
that degree of necrosis is unusual for even extensive FITMs. I wonder if this cat also had some sort of vascular, like systemic hypertension or something that would lead to ischemia of the entire iris in that region. It's kind of weird.
For those that couldn't hear Dr. Shah, she said the degree of necrosis in this neoplasm is unusual even for an extensive FITM. So she's postulating that maybe there is some sort of vasculopathy or something that could have caused this very profound necrosis. And in this case, I don't think we saw any vascular changes, but that's a good point.
Yeah.
So. All right. So if there are no other questions, I'll move on to my next one. So this is also a globe from a cat. This is an older cat, a 17-year-old female spayed domestic short hair. And this globe was diagnosed clinically with glaucoma. It was being treated with topical medications. All of a sudden, it doubled in size and became non-visual. They also mentioned that during surgical prep for the enucleation, the globe did rupture and start to drain fluid. Other things potentially of relevance, this cat does also have a history of chronic vomiting, though that might be a red herring for all of us. So here is the gross hemisection of this globe. Grossly, we described that the cornea was bulging anteriorly, right here. And there's this area here. There's a little bit of conch still on here, and I'll show that histologically, where there's just kind of this thickening of the limbus, maybe of the cornea. It's a little bit hard to see kind of the crisp demarcation that we usually see kind of at the limbus, as we're seeing on the other side here. Other things that we had mentioned, that the iris was kind of bent back in kind of a funny position in areas, and then the lens was cloudy. So this is the same globe. This one I'm just going to jump right to the putting it on the stand. All right, so again, the cornea is on the left, posterior segment is going to be on the right. So we have an intact cornea here as we follow it over to the ventral limbus. There is a rather large full thickness perforation, and this is right at the limbus. So this is our sclera, kind of limbus would be here-ish. We have our perforation, then we pick up peripheral cornea. And we will look at that a little bit more closely coming up. As we move back, perhaps it's a little bit subtle, but if you look, there is an extra layer of cells carpeting the uveal structures that should not be there. What's that?
Purple eyeliner.
Purple eyeliner, yes. The uvea is wearing purple eyeliner. We have more than here. So circumferentially, it's just carpeting the anterior uvea. We can see it starting to kind of wrap around and line the posterior aspect of the sclera and cornea. As we move back, this lens, there's a lot of artifact associated with just processing of the lens, which happens, but there is evidence of a cataract too. We have some mineralization of the lens fibers, some liquefaction. And then posterior segment, all things considered, is rather unremarkable. So we won't spend too much time on that. We're gonna just start with these cells. If I can focus, there we go. So these cells look, funnily enough, kind of innocuous. Like they look pretty well behaved. They're lining up very nicely. They seem well organized, but they should not be there. These are imposters in the eye. And to kind of bring that home, not only are they lining the uveal surfaces, there's areas where they're infiltrating the iris and ciliary body stroma as well, making these kind of tubular structures. In areas where they're doing kind of more of this carpeting behavior, they form kind of this simple layer of columnar epithelium. There's areas where they get a little bit more jumbled up and almost make this kind of pseudo-stratified appearance. And I call these epithelial just because of this kind of columnar shape that they have. They have pretty well demarcated borders. So these are all features of an epithelial population. And there are areas, maybe I should have dotted it, where they do have kind of this apical clearing, areas where they're almost taking on a goblet cell phenotype. Maybe like here, perhaps. And there are areas where they do pick up a little more atypia. So I show where they're infiltrating the stroma. We have a little bit more anisocytosis, anisokaryosis, tons of nucleoli, areas where there are some mitoses as well. So it gets a little mitotically brisk. So this population here, as I mentioned, an imposter to the eye, this is a neoplastic epithelial population. This particular behavior where they're carpeting the uveal structures, they are still exhibiting infiltrative behavior, is most consistent with a metastatic carcinoma to the eye. A very common site for the primary neoplasm to be is in the respiratory tract, which is maybe where I'm getting at with these goblet cells. But that doesn't rule out there being a primary neoplasm elsewhere, like the GI tract, say. This cat does have a history of chronic vomiting, though what cat does not? So who knows about that? Bottom line is this cat does need to be staged to look for a primary tumor. I want to give Dr. Shaw a little bit of time to show at least one case. Okay.
It's better for me to stop, but probably just wait till next time.
Sounds good. So other features. So this is going to be our iridocorneal angle, or what used to be. We can see these neoplastic cells that are carpeting the anterior iris kind of form this almost peripheral anterior synechia on their own, where they just efface the iridocorneal angle and they're kind of connecting the iris to the cornea. So we have good reason for there to be glaucoma in this case, which clinically was diagnosed. As we follow these cells, we can go on quite the journey up the perforation site.
Sesames,
Yeah.
gone.
And then, so this is going to be the surface epithelium. So the conjunctival or corneal epithelium almost meets up with these intraocular neoplastic cells.
United.
So they mentioned during surgery when they were cleaning the eye that it ruptured, presumably just given how far up these neoplastic cells have gone. This area has been compromised for a long time. It was probably held on by just like a thin strip of epithelium or stroma. So this was just asking to perforate. So I imagine cleaning the eye was just the final straw. And adjacent to that, there's a ton of fibroplasia. So again, just kind of hones in the fact that this has been going on for a little bit of time here. Just a lot of reaction in the stroma. Yeah, there is. I guess I should mention that. There is some lens material that's hanging out here at the perforation site. I think we'd stared at this lens for a very long time, wondering if this truly was a ruptured lens, which certainly it could be. I would not be surprised. But didn't see an overt kind of lens capsule rupture that was convincing. There's areas with more like sharp edges. We also didn't see any inflammatory cells kind of within the cataractus lens. So we kind of just wrote it off as artifact, but I think if someone had tried to make an argument for lens capsule rupture, they probably wouldn't be wrong. Okay. And then lastly, going to the back of the globe, they diagnosed glaucoma in this case, which is something that we weren't able to corroborate just because there were still ganglion cells in the retina. So we don't have that interretinal atrophy we should see. Optic nerve head, we didn't get the most ideal section through it. This is probably just kind of a little bit at the edge where we're just starting to see the lamina cribrosa. So it's possible there's optic nerve head atrophy and we're just not quite catching it. At the least, there's a little bit of gliosis in the optic nerve, which again, we can see with glaucoma, but is not pathognomonic for it.
Can you go back to the anterior chamber real
of
quick,
course.
Kelsey? Since we have a few minutes to kill now.
Yeah, of course. Let's talk.
So, well, carry on first. Go ahead and talk about the case, and then I'll come back to that. So, never mind.
Don't know if I have too much else to talk about, honestly. So yeah, in this case, biggest thing was going to be that metastatic carcinoma to the eye. We strongly recommended that this CAD be staged to search for a primary tumor. On top of that, we do have this corneal perforation, which is presumably secondary to that migration of the carcinoma. And then lastly, glaucoma, which again, we couldn't confirm histologically, though we have very good reason for there to be secondary glaucoma in this case.
Cool.
Yeah.
One thing I wanted to bring up, so it's never good to have mucin producing cells in your anterior chamber. So they produce a lot of shmoo that clinically so this cornea was obviously pretty opaque clinically, and probably clinicians couldn't see into it at this point. But these neoplastic cells that are producing mucin will exude that stuff into the anterior chamber. And so there's often like a cloudiness or debris in the anterior chamber, maybe could be described as being fibrinous clinically. And so that's often a common feature when you have a metastatic carcinoma with goblet cells in it, that there's like this debris in the anterior chamber. And I think that's important to note as pathologists, because I think that's something that's quite visible to the clinicians and the owners before the corneas go bad, if they do. So I think that's kind of important. We're working on a case series of these to publish, so.
And another thing that's interesting to think about on the same line as with metastatic squamous cell carcinomas to the eye, where they have that carpeting behavior and the cells, they start to release keratin debris into the ocular chambers that will look clinically like keratic precipitates or cells floating around. Yeah, that's a cool thing. Yeah, and we don't get that information very often.
Yeah, another thing real quick with cells releasing keratinized debris into the anterior chamber, when you have surgical or traumatic implantation of corneal epithelium into the anterior chamber, so even non-neoplastic squamous epithelium that will slough cells into the anterior chamber, they are not wanted, and they induce crazy inflammation when they're in there, keratin specifically. You asked how many cases. It's only 11, but we only included cases that came with a history of a tumor elsewhere. So most of them have had a mass in the lungs. We have tons more where we don't have that information, because this is like sadly common for us to get this.
Yeah, and in terms of the primary location, let's put it that way. In cats particularly, we don't get, as Gideon just suggested, a history of necessarily right away a history of a primary tumor elsewhere, but from the cases that we did receive, either initial presence of a tumor or later on they described a tumor was found, the majority of them were of respiratory origin, nasal or pulmonary. I remember from the top of my head a few that were like gastric carcinomas or intestinal carcinomas. But the problem for us is that once we get diagnoses like that, the patient ends up with an oncologist, and we might lose track as lab decators primarily to the ophthalmologists.
And they're primarily associated with the iris and ciliary body initial presentation.
Yeah, and that's an important point. So we're very biased in the cases that we look at and diagnose metastatic tumors in. I think generally speaking, tumors that metastasize to the eye do end up in the choroid more commonly. But because the cases that we see are being removed from a living animal with a known eye problem, and because the anterior segment is more readily accessible and noticeable when there's a problem to the owner and to a clinician, I think we have a biased population, so that mostly when we see metastatic stuff, it's in the anterior segment. But I think most common overall from like necropsy cases, the choroid is more affected. So that's a little caveat there.
All cases.
Right. Thanks everyone for joining us online and those who came here in person. See you guys in 2 weeks.
Thank you.
Oh, yeah, sure.